about the issue of compassionate access is to look at some actual cases. And I'd like to present two recent Canadian cases. One involving a very young woman in her early 30s called Holly Hill, who had stomach cancer, and the cancer had spread through her body. It had metastasized. Her physician had tried an experiment, had received approval for an experimental kind of chemotherapy, and it had worked for a bit, but now it wasn't working, and she was facing imminent death. And he wanted to give her, and he did give her, a vaccine that was his own vaccine that he'd invented and manufactured. And the issue was whether, in order to give her hope, because her situation was pretty close to hopeless, and in order to respect her wishes for a last chance at life, whether it was legitimate for him to administer this unlicensed, unapproved therapy, which he did without permission from the British Columbia Cancer Agency. So that's the case of Holly Hill, 34 years old. The second case involves a Toronto man called Darcy Doherty. He was in his late 40s, but had young kids and had malignant melanoma, which had spread through his body. It had metastasized to his brain. And he too was at the end stage of his disease. So the issue was whether he should have access to a very early stage experimental drug, a monoclonal antibody that might have been effective at saving his life. And he wanted access to this drug, and his doctor tried to get approval, but the drug company Bristol Myers Squibb said no. So here are two cases: patients who are dying, patients whose doctors want to give them hope, and patients about whom many people would say, look, they have nothing to lose. How can we deny them compassionate access, even though the drugs don't have good scientific evidence? So that sets the basic situation. The case against is that it isn't the doctor's duty to give a patient hope if by giving a patient hope is meant giving the patient a falsely optimistic prognosis, or giving the patient a sense that there's a genuine chance that they might live. Because the truth is that at the end stage of cancer, once it's metastasized and the patient is near death, it would require a virtual miracle for any of these chemotherapeutic agents to provide them either with a significantly longer life or with a more comfortable dying. So the hope is a false hope, and what it does is it denies them the opportunity to come to grips with the fact that they're dying, to face their death, and to make something meaningful and significant. I sometimes suspect that giving a patient hope by attempting to get access to a last chance therapy is a way that some doctors use to avoid a conversation with the patient, which can be quite uncomfortable, where you have to tell the patient that really, practically speaking, there's no hope. Have to enter a caveat. Very occasionally, a dying patient, let's say patients who had pneumococcal pneumonia prior to the era of antibiotics. Penicillin comes along. Previously, 9 out of 10 patients with pneumonia would have died. You give it to 10 patients and they all live, or 9 of them live. You don't really need a long clinical trial lasting over years with thousands of patients. You know that you've got a miracle drug, but that's really rare. And for patients who are dying of cancer, it's virtually unheard of. The drugs we give them often make them sick as a dog and can shorten their lives and can really give them a wretched dying process. So they do have something to lose. And that was the second point I wanted to make, is that you have nothing to lose is almost never true. You may not be able to save your life, but for most of us, for most people, the opportunity to have those end-of-life conversations with the people you love, your spouse, your kids, your siblings, your dear friends, is important. And being comfortable, having a kind of dignified death where you're not puking and you don't have continuous diarrhea and you're able to be yourself and make something significant out of it, that's important. So they do have something to lose. And that's, I think, a legitimate hope, that you won't be abandoned, that the physicians will keep you comfortable or as comfortable as possible so that you can make something significant out of the last couple of months or couple of weeks or even couple of days of your life. Well, one of the arguments is patient autonomy. Patients have a right to know that there is a drug out there. It may not have been licensed, it may be in a very early stage of testing, and it should be their choice. So it's really an appeal to the value of patient autonomy. What worries me about this is that dying patients tend to be desperate, especially when they're younger, as both Mr. Doherty and Ms. Hill were. And if you offer them this option, if you say, there is a possibility, even though the cancer is spread throughout your body, it's not great, but there's a possibility that we might be able to save your life, virtually all of them will opt for it and will have a wretched last few days or weeks or months of their life when, if they had a more realistic sense of what medicine can do for people who are in the end stage of their disease, I think very few would opt for it. There are drugs that have been licensed. Avastin would be an example, which is primarily used for colon cancer, that cost tens of thousands of dollars and may give you an extra few months of life, but with a very poor quality of life. I would pay $30,000 not to have Avastin if I were dying of colon cancer, but when it's offered to patients as something that might prolong their lives, many of them feel obliged to accept. So I wonder whether doctors should be holding out this last faint hope to patients, given that the patients are desperate and can be easily exploited. Well, I would say to such a person, perhaps they should pray then, because the chances, once they're in the end stage of their disease, the chance of an experimental drug helping them is just about as good as the chance of a miracle from heaven. There is another point, which I haven't made yet, and it appeals to social utility, to the effect on society, because there are experimental drugs, and we follow a system whereby they have to be rigorously tested in clinical trials. So large numbers of patients will get the new drug, patients who meet the criteria for being in the trial, and an equal number of patients will be put on placebo, and no one will know which. And that's a way we protect patients from quack remedies that may do them more harm than good, or that may be useful. It's a way we protect our healthcare system from wasting fortunes of money. My fear is that if we allow patients compassionate access to experimental drugs, there'll be no incentive for going in a trial. After all, why take a 50%? If you're desperate to live, why take a 50% chance that you may be one of those randomized to placebo when you can get 100% certainty of getting the active ingredient by applying through compassionate access? So if we're going to have evidence-based medicine, and if we're going to screen drugs so that we're at least reasonably confident that they do a little bit more good than harm for most of the patients who are going to take them, we've got to have these clinical trials. And I think potentially a system in which every Canadian doctor was scrambling to get access for his or her patients at the end of life to drugs that haven't been licensed and for which there's no good evidence that they will provide more benefit than harm, that would be to go in the wrong direction.